Yes, ready for Dr. Dia.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. We will start, inshallah, the second session today about the upper GI prime problem. And I ask the speakers to adhere to the time in order to catch the prayer time, inshallah. Firstly, we start with Professor Yano from Japan, and he give a lecture about the laparoscopic hiatal hernia repair, how to reduce the recurrence rate. Okay?
Assalamu alaikum. I Fumiaki Yano. I said, hello, good afternoon. My name is Fumiaki Yano in English. And this is, I went to Luxor and Pyramid. It was very good. Do you know this? Is it Pyramid? This is Mount Fuji. So I came here from Japan, and Japan is really very famous for cherry blossom in spring season, and it is maybe around the end of March. And our hospital is placed in the center of Japan, and this is the mid one. This is a hospital, and it is in front of Tokyo Tower. And right picture is a shadow of Tokyo Tower, and mid one. I took this picture by myself from airplane approaching to Tokyo Haneda Airport. So my hospital is maybe 30 minutes by taxi from Haneda Airport. So let's move. Surgical treatment of hiatal hernia is well standardized. Laparoscopic fundoplication is safe and has a good success rate of around 90%. However, hiatal hernia is benign disease. So, hiatal hernia is not cancer. They never do lymphatic metastasis, and no hematogenous metastasis, and no dissemination. It's not cancer. So, if we do surgery for benign disease, we have to relieve patient's symptoms, such as sore throat, chest pain, appetite loss, heartburn, and epilepsy and regurgitation, and so on. Oops. So, I think benign surgery is more difficult than malignant surgery, because if it is cancer, we just remove the cancer. But for benign surgery, we have to remove patient's symptoms. So, but this is my opinion. If we do surgery, we are needed to stop taking medicine and try to reduce hiatal hernia recurrence. The aim of the study is to examine the treatment results for hiatal hernia and to identify treatment result strategies. We have 4 types of hiatal hernia, as you know. Type 1 is sliding type. Type 2 is paraesophageal type. And type 3, mixed type. And type 4, a composite type, such as T-cut transverse colon, small intestine, pancreas, and spleen is going up to mediastinum space. And size of hiatal hernia, type 1 is small, and type 4 is larger. So, size of hiatal hernia nearly equal size of hiatus. So, if we do surgery, is same procedure acceptable? So, I grouped I divided 3 groups. First, small type 1 hernia, such as less than 3 centimeters, and large type 1, larger than 3 centimeters, and type 2 and 3 and 4, it is large hernia, it is group 3. Its results, and age, sex, and operating time, and intraoperative complication has significantly differences. So age, type 1 is younger than the others, and but sex, small type 1 is 3/4 of patients are men, and large hernia, almost half patients men. And for type 2, 3, 4, 3/4 are women. Overall time is longer than type 2, 3, and longer type 2, 3, 4 because it's large hiatal hernia. And intraoperative complication was vagal nerve injury because such equals large hiatal hernia repair. So when we start resection, sometimes we injured the vagal nerve. This is a recurrence rate from 1995 to 2011. Triangle is recurrence rate, and gray is recurrence negative, and dark gray is recurrence positive. Recurrence rate of small type 1 was 10%, but the others are almost 20%. So we think something is needed for large type 1 and 2, 3, and 4. So we added mesh reinforcement from 2011. Small type 1, less than 70 years, 75 years, and less than BMI 28, we do laparoscopic fundoplication. And small hernia elder than 75 years and or BMI over 28, we do LF plus mesh reinforcement. And large type 1 and type 2, type 4, we did mesh reinforcement. Recurrence rate before and after mesh reinforcement. After mesh reinforcement, recurrence rate of large type 1 markedly decreased 22% to 3%, but still high for type 2, type 3, and type 4. This is with or without mesh reinforcement. Recurrence rate in type 2, 3, 4 was still high, but in large type 1 was 0%. So mesh reinforcement controlled recurrence of hiatal hernia. But something is needed for type 2, type 3, and type 4. So we added gastropexy from 2016. We put it on the body of the anterior wall of the stomach and fixed it to peritoneum. So type 2 and type 3 and type 4, we added laparoscopic fundoplication plus mesh reinforcement and gastropexy. Recurrence rate after gastropexy, no significant differences anymore, these three groups. So gastropexy was effective for type 2, 3, and 4. So compared to the effect of gastropexy for type 2, 3, and 4, patients who underwent laparoscopic fundoplication of hiatal hernia from January 2011 to December 2022, N equals 365, and type 2, 3, 4 patient was 77. It's divided RF plus MR on RF plus MR plus GP. It means left one is without gastropexy and mesh reinforcement plus gastropexy. Recurrence rate of type 2, type 3, 4, type 2, and type 3, and type 4. Recurrence rate was 40% versus 80%. So gastropexy controlled recurrence of type 2 and type 3 and type 4. For the future, recurrence rate in type 2, 3, 4 was well controlled. Mesh complications is reported, such as migration, stenosis, erosion. So mesh is foreign body. So if it is possible, we don't want to use mesh. So this is a strategy from January 2023 at Jikei University, my hospital. Type 1, less than 3 centimeter, 75 years, less than 35 years, and less than BMI 28. Just simple fundoplication. We do TPE fundoplication, and over 75 years and or BMI over 28, we do mesh reinforcement and large hiatal hernia large type 1 hiatal hernia, we do mesh reinforcement. And type 2, type 3, type 4, we do just simple fundoplication and gastropexy, no mesh. This is a video. This is the stomach. We pull down to the abdominal cavity. And we divide, this is centered spring, and we divide all short gastric vessels and mesh excision of abdominal wall side using LCS. And we conserve anterior nerve of vagal nerve, anterior branch, and we preserve posterior branch vagal nerve 2. And so now we do hiatal hernia repair. We usually use 3 stitches, at least 3 stitches, and maybe median is 6 or 7 stitches. Centered posterior nerve, posterior branch of vagal nerve. So we close the hiatals. And move to pay fundoplication. So we do shoeshine maneuvers as usual and drop test. And we use 4 stitches and 4 centimeters for the lap. And this is gastropexy, 3 stitches to the peritoneal wall. So, mesh reinforcement reduces recurrence of large type 1. And mesh reinforcement plus gastropexy reduced recurrence of type 2, type 3, and type 4. And now we are ongoing to determine laparoscopic fundoplication plus gastropexy for type 2, 3, 4 is feasible. Shukran. Thank you.
Thank you. If you faced a short esophagus, especially with large types of hiatus hernia, what can you do for this short esophagus? Short esophagus.
Oh, yes. We do to-pay fundoplication and gastropexy. Not do chorus.
Is it visible to access a good length of the esophagus intra-abdominally?
Yeah, I think so.
Okay. Any questions?
You perform anterior gastropexy, so you don't perform posterior gastropexy, like fixing the wrap posteriorly to the corona.
We have 2 shoulder stitches, and wrap and right screws, and wrap and left screws, and anchor stitch for wrap and hiatus.
So you prefer this, or you prefer?
Oh, we do this now. Yes, now too.
Again, the same question, but another model question, Dr. Sarwat. It's about the sliding hiatus hernia. It's the same techniques. Sliding hiatus hernia by the same techniques. Sliding hiatus hernia. Sliding hiatus hernia. Yes.
Same techniques.
By the same techniques.
Yes.
Or were different techniques.
Same
because
techniques.
we can offer that the esophagus is shut it up and the stomach is get up with the esophagus used from recurrent esophageal reflux esophagitis and shorten some centimeter of the esophagus.
We did chorus for shortened esophagus, but it was not a good results, so we stopped Coris.
Thank you for your report. I have two questions. The first question is, how many patients under surgery for hiatal hernia per year?
Right, hernia?
For hiatal
Maybe
hernia
900.
for 1 year, 100.
Oh, one year.
For 1 year, yeah.
One
how
year.
many?
We have maybe 60 this year.
60.
Yeah.
Okay. And the second question, you show the video that the vagus nerve is punched between the legs after crude repair. It's not dangerous for our opinion. It's not some stenosis of
Here, sorry.
vagus. What? A vagus nerve you show in the video. The vagus nerve is vagus. Vagus nerve. Yeah, you show that between the leg, between the crura after crura repair. Yeah. In the outside of the
The
man.
posterior branch.
Where is he? Yeah, yeah, yeah. The vagus is outside, not under the crura.
Outside.
Yeah,
Outside the lap. Usually the outside.
outside. Okay.
Okay, thank you. Thank you. شكرا.
Thank you very much.